This is an open lecture on the Clinical Nurse Specialist Team at the RHN, supporting a patient from admission to discharge. Thank you so much for joining us. This talk is being recorded. If you have any questions, we'll hopefully have time for a Q&A at the end. You can use the Q&A button, which should be at the bottom of your screen to the right-hand side. This talk will also be available afterwards on our website for any of your colleagues or friends who've missed it. So without further ado, I'd like to hand over to Louise. Thank you.
Hello, good afternoon. Welcome to the RHN. So as you can see, this talk is by the Clinical Nurse Specialist Team, and we're going to talk you through how we supported a particular patient last year from his admission to RHN right the way through to his discharge. So the patients at RHN, for those of you that are unfamiliar, have all acquired a brain injury, which leaves them with profound neurological problems, and as a result, very complex nursing needs. Our service delivery as a team is really looking at the individual needs of each patient and tailoring our service or their requirements, what they need themselves. So it starts really on admission, looking through during their stay and then preparing them for discharge. So as a team, we have 6 specialist nurses who cover tracheostomy care. And we have roughly about 35% of our patients have a tracheostomy tube. Enteral care, which involves feeding tubes, feeding devices, and 78% of our patients generally have some kind of enteral device in place. Continence management, of which about 90% of our patients have continence issues. Tissue viability, palliative care, and infection prevention and control. So it's a very unique team in that we have just over 200 beds, 220, 210 beds at the moment. And to have 6 specialist nurses working in one place is very, very rare. Normally, if it was a bigger hospital, perhaps you would have specialists coming from other trusts, other community services. So we're very lucky that we all work under the same roof and we're all here for our patients. So I'm just going to hand over now to our infection control specialist nurse, Manette, who's going to give us the background of the patients and also put this into context as this all took place last year.
Thank you, Louise. Good afternoon. I'm Manette, and I'm here to give you a brief discussion on the patient A, who is in our case scenario. He is a 24-year-old male, previously active and fit, no known comorbidities, and he lived with his mother. Unfortunately, in February 2020, he suffered from a severe hypoxic brain injury, and this is due to a out-of-hospital cardiac arrest. While he was an inpatient in the hospital, he contracted COVID-19, and that was in March. 2 months later, he was referred to us, and we admitted him in May 2020. As you all know, the pandemic was declared in January 2020, so we were looking after him during the pandemic. And just to give you a timeline, so it has a bit more meaning to what we were doing and what we plan to do while we were facilitating the care of this patient. We were on lockdown from March 10, 2020. So we stopped visiting from the 14th of March. And although we opened our doors for admission in April, all our admissions are carefully assessed and controlled. And we have to make sure that we manage family expectation before they come to us. Patient A lived with his mom. He's very young, and his mom and family would like to be involved with his care. So we knew this prior to patient A coming to us, and that's part of our care package for patient A. So from an infection prevention control point of view, we need to make sure that our care is safe and the facilitation of his discharge is also safe, which involves other people other than our staff. Prior to coming to RHN, we have systems in place to make sure that we have a COVID-19 entry control. So all admissions are screened on day 1, day 7, and day 14. All admissions, including those who have previously contracted COVID-19, will have to undergo 14 days of strict isolation. Because we knew his status prior to coming to RHN, we were able to admit him with 3 other patients, almost all at the same time, or they came in within days to RHN, and we put them on a shared bay. And they all completed their 14 days isolation. So they are, patient A is only here for 12 weeks, well, funded for 12 weeks initially. And 14 days is quite a long time not to do anything and start the rehab assessment. So we made sure that all initial assessment by our allied health professionals are done, but in the bedside. We also have to modify the personal care to make sure that the other patients who are in the ward are not exposed. We limited face-to-face contact, so only essential assessment and medical team, clinical nurse specialist would only come and see him if needed. Otherwise, it would be a virtual assessment. Family involvement in the first 14 days, this is the isolation period, are virtual visits. We have a program called Stay Connected, and this is when we facilitate FaceTime, Skype, Zoom, so that families can visit their loved ones virtually during the pandemic. So then part of the care package, as mentioned a while ago, was to make sure that we also facilitate family and carer training. To make sure that we facilitate this safely, IPC had help in terms of making sure all the carers or family will be tested. So screening at the time was not PCR, but we have lateral flow device test. And we asked them to come in half an hour earlier of their schedule so we can do the lateral flow testing. And they have to be negative to be able to attend to these trainings. We also provided scrub suits so that they can change from their civilian clothes to scrub suit before they attend the training and have a closer contact with the patient. Fortunately, we have an empty ward, so we were able to simulate the clinical setting, the bedside. We use equipment, and they were able to practice outside the clinical area, making sure that other patients are not exposed to other people. And we also changed our infection prevention general guidance, wherein everyone who enters our building must perform a hand hygiene in the reception area. We would also give them a fresh surgical mask before entering the building. Even if they have a surgical mask, we would replace it with a fresh one. We also require them to complete a visitor's checklist. So the visitor checklist has questionnaires that ask, have they been exposed to a symptomatic person? Have they traveled recently? Have they tested positive recently? Or have they been in contact of a positive case? All of this has to be completed before they are able to enter the building. I will now pass you over to Luis.
So I'm speaking really now on behalf of Karen, who's our palliative care nurse specialist, who unfortunately this afternoon has been called off to a meeting. It might seem strange to put palliative care really at the beginning of this patient's journey, but I think it's really important to recognise the patient had a severe injury, and as part of the discussions before he got here in the acute hospital, certain things had already been put into place. So he had already the family had discussed that he was not for resuscitation, so they had agreed to that decision. Also within the realms of that, the intensive care unit where he was, the team there had discussions about feeling of care, really, about establishing what should happen if he needed further critical care. And at the time it was discussed, they agreed that he wouldn't benefit from readmission to critical care should his condition deteriorate, unless there were meaningful changes to his neurological status. So what that meant was that in the event of treatment escalation being needed, they had to really look at what was appropriate for this young man. And they decided that treatment for reversible things like infection, for example, IV fluids, IV antibiotics, that was appropriate, but perhaps other interventions would not be appropriate. So that was discussed with the family and that was put in place. So in preparation for discharge then, that plan was reviewed in that you still need to be looking at advanced care planning. Although this young man was not imminently dying, it's still important to have these discussions with the family and to make sure that everyone knows where the documentation is and can access it. So it was about having conversations with the family about his wishes and wants, his perceived wishes and wants, the family's wishes and wants, perhaps discussing preferred place of care and death should his condition have deteriorated. And then making sure those decisions were documented and that information was passed into the community as he was going home, so that the GP and any community services were aware of what had been discussed and what was already in place. So now I'm going to pass you over to Christine, who is our tissue viability nurse specialist.
Hello, good afternoon. So I'm Christine, I'm the tissue viability nurse working here at the RHN. So pre-admission wise, for all of our patients who are on the active list waiting for admission to RHN, so we do an admission, pre-admission assessment. So it is structured based on all the care needs that a patient might require. So if it is identified during that pre-admission assessment that the patient has an ongoing skin disorder or the patient has any wound, then the assessment will be redirected to me so that I can follow up on more information regarding the management and for any also possible handover from my counterpart TVN practitioner from the other trust. So if the patient comes with if the patient will come with a skin disorder or a wound, then we would be looking into doing like body mappings, identifying the pressure areas involved if it is a pressure damage type of wound. And if not, then we would also do a handover of what is the specific management the patient is on or the patient will be requiring when he comes to us. For patient A, he did not have any skin issue pre-admission wise. And also when he was admitted to us and during his stay, he did not develop any skin disorder or any pressure-related type of issue or any other type of wound during his stay with us. So what we did with him regarding his care is just to maintain the routine skincare for him. So he has his care plan would include like having a shower 3 times a day, and he is going to have a bed wash on alternate on the other day. But he was using his own skincare products. He did not have any sort of a prescribed product from our point of view because he was tolerating his products really well, and his skin was responding really well to the product that he'd already been using. So on a day-to-day basis, so during his stay here, so the staff on the wards will be checking his skin daily, and if there's any skin issue, it will be escalated and reported to the relevant members of the team, and that will be including me, the TVN. The preventative measures were also implemented for him, and this is not just only for his case, but also for the rest of our patients. So Waterloo score skin risk assessment was done, and he was scoring a 14. So he is at a risk of skin breakdown based on that score. So he is nursed on a pressure redistributing foam mattress. And this is the type of mattress that we generally provide for the majority of our patients here at RHN as part of our preventative measure strategies. If a patient is deemed not anymore meeting that need, so meaning the current pressure redistributing foam mattress is not providing the patient with pressure relief that he or she might need, then we would do like a skin assessment together with the post-dual management team, and we will trial this patient on another type of support surface, which would be a dynamic type, so like an air mattress for this patient. So he was being repositioned 4 to 6 hourly in bed, which he was tolerating really well, skin-wise and also comfort-wise. He was provided with a Rhea Azalea tilt-in space wheelchair, and he was sitting up for 5 to 6 hours every day. And so he was tolerating that really well on a Vicare pressure relieving wheelchair cushion. So he has nutritional support led by his dietitian the ward dietitian allocated to the ward he was on. And with regards to looking after his skin, so MDT, relevant MDT members, multidisciplinarity members also have input. So to help with maintaining his skin and also to assist in positioning him, he had appointments with our own tone clinic, and he had some botulinum toxin injections to just help with the management of his contractures and his increasing global spasticity. Discharge training, there was none required as he was only needing maintenance of his routine skincare at home. But we did liaise with the community team care package that was put in place for him when he went home regarding the equipment that he was needing and also handover of his guidelines. And that is it. So I will now introduce to you Nettie Solis, who is our respiratory care nurse.
Hi, good afternoon. I'm Nettie. Patient A came here with a Traco Twist Plus, which helps him to maintain his airway and manage his secretion. And this is during admission. She has also a subglottic port, which we've noticed that it's got loads of secretions averaging around maybe 10 to 30 meals a day. We also notice around the stoma area, there's some leakage, just minimal leakage, whitish secretion around his stoma. And the appearance of the stoma is just a bit crusty during admission, and there's a minimal overgranulation just on top of the subglottic port. So during his stay with us, nurses in the ward, they do normally refer it to me or to the doctors if there's any concerning about tracheostomy. With regards with his the secretions about his subglottic port, we monitor it every 4 hours and try to document it so we can monitor it if it really needs to be increased in monitoring. The staff also, it was also observed that patient A is more hypersensitive when you touch him, or sometimes when you're doing a personal care to him or trachea care. He normally cough and sometimes regurgitate. So it was also referred to me why this happened like that. So we plan off because of the Traco Twist Plus. It looks like, because this patient is like an average, the height is just an average patient. So I have a plan of changing it to a smaller trachea, shorter trachea. It might help him with those sensitive during personal care. Before that, I do refer him to ENT doctor, which will comes here every month, and we agreed to have it changed to a Portex 7.5 cuff, still with the subglottic port. And so we do review also, we change also the trachea every 28, sorry, every 28 days and review as needed. And what we did during his daily tracheostomy care. Normally we do the stomach care daily. We change tracheostomy tape, inner tracheostomy tape, the trachea dressings, checking all the stoma sites if there's any granulations or any macerations. We do the suctioning bit. We suction patient if needed. For patient A, we normally suction him every 4 hours. But with the subglottic port, because we've noted that secretions is quite a lot, I advise them to aspirate secretion subglottic port every 1 to 2 hours and document it. So, and also cuff pressure is one of important thing is to monitor the cuff pressure for the tube. Every tracheostomy intervention. So to maintain it in an acceptable level of the pressure, to prevent also further risk of aspirations. Humidification is also one important bit of having a trachea patient. And yes, it tends to have a thick secretions, but we use a artificial nose, or the Swedish nose that we used here for his humidification, and a nebulization for him was every 4 hours. And inner cannula is also inspected and changed as needed. Our routine is every 4 hours, but if it's needed to be changed every 2 hours, we do change it. And oral care is also one important thing that we do for at our trachea patients. We do a twice a day oral care for the patient. And lastly is for the training for the discharge. Because the mom is quite very involved with patients care. And 3 weeks before of his discharge, we did a trachea training for her, and we did I think three sessions. The session involves like for the mom to feel confident when patient A goes home, and we did a training about suctioning, inner cannula changing, cuff checking, aspirating subglottic port, and infection control also was also advised to her how to deal with infection control. And identifying respiratory distress, and all of these things are done with only if there's any problem arises during the thing, but all of the care is provided by the clinical stuff that is provided by the care package during the discharge. Yeah, I will hand it over to Luis, which is our enteral nurse.
So now with my own clinical hat on, so I'm the Enteral clinical nurse specialist. As I said, this patient had had his hypoxic brain injury back in, I think it was the beginning of the year, the February time, got to us in the May. He had had a peg already placed. It had been placed pretty soon after his injury. So he was completely nil by mouth and relied on the tube for all nutrition, all his hydration and medication needs. As is often the way with patients here, a lot of our patients have got significant changes to their swallow. So many patients, in fact, about 78%, will have some kind of feeding device, permanent feeding device, placed before their admission to RHN, either to cover all their needs or to provide support, say partly meeting their nutritional needs, or perhaps just overnight. This patient, however, needed it for absolutely everything. So regular mouth care was really important, especially for a patient who's nil by mouth. But that's basically, he just relied on his tube for everything. On admission, his stomach was very overgranulated. So the first thing we needed to do was to treat that. That involved a cleaning regime, dressing regime. I also used steroid cream. So twice a day, cleaning it with an antimicrobial wash, applying the cream to the affected area, and then using an adhesive dressing, and then reviewing him every week. And gradually things got to improve, and after 3 weeks we could discontinue the treatment. And then once really that had been treated, it didn't recur, and his stomach care was just basic, what we would call basic daily care, which was just cleaning the site every day as part of his personal care, and then also advancing and rotating that tube. So for a bumper retained peg, it's really important to prevent something called buried bumper syndrome. So all our ward staff are trained to advance and rotate tubes to prevent that from happening. So then in preparation for discharge, we needed to get the family, so the mother and the carers who were going to be part of the care team, in to train them in how to look after patient A's stoma, how to look after the actual tube, how to give medication, and how to set up the feed. It took, I think we did it over one afternoon. We had everybody in, I think we had the mother in separate and then the carers. And it was basically going through each bit just to make sure we obviously couldn't have the patient with us at the same time. So I brought in spare tubes and things like that so that they could handle the tubes. They could look at what it was they were going to be using, all the equipment. So with regard to stoma care, we looked at what the daily regime was going to be, how it was going to be cleaned, and also how to identify when things weren't going quite so right. So how to identify perhaps overgranulation coming back, infection, and also what they could do about it. So that would be where we would say, this is when you need to call your GP, or using the home enteral feeding company's clinical nurse advisor. So as long as they knew where to go if there was going to be a problem, that was really all that we were just trying to get across to them. With regard to tube care, again, it was important that they knew how to advance and rotate the tube to prevent buried bumper syndrome. Also, we taught them how to replace some of the plastics on the tube, so simple repairs really. What to do if the tube became blocked, how to fix that, and also how to adequately flush a tube. We always teach people to flush a tube before and after giving any medication and before and after giving any feed. So the other part of moving from hospital to home is to look at the regime, the feed regime, the medication regime, because of course what works here in a hospital setting may not translate quite so easily to a home regime. So we looked at timings, also about carers, when they would be coming in, their shift pattern, to make sure that the whole 24 hours was covered. We made it as easy as possible to reduce the intervention that was needed, but also to work around family times, carers visits, etc. And then that also meant that we had to look at, was it appropriate to use a pump or perhaps bolus feeding or a combination of the two. Actually, for patient A, we just used pump feeding, and I think he was fed overnight in the end was the easiest thing, to set it up before when the last carer visit came in, and then fed overnight, and then it was all disconnected during the day. It's also important when moving into home and into the community that the family and the care team understood the role of the home enteral feeding company and the support that they offer about deliveries, etc., so that they knew again where to go to for help. So now, finally, I'm going to pass over to Marie, who is our continence nurse specialist.
Louise. Good afternoon, everyone. I'd just like to start off with a little bit about continence. Continence, or the ability to control when you want to urinate or empty your bowels, is actually a vital component of a person's health and well-being. Unfortunately, problems with continence are common following a brain injury, particularly in the first several weeks. For many people, this loss of toilet control is a very sensitive issue, not only for the patient, but also the people around them, and can have an impact on daily life. Bladder and bowel continence problems can also occur alone, and they can also occur at the same time. The range can be quite severe. It can be the severity of a small leak or to total complete loss of function. Some people will experience continence problems from day to day, and others will experience this issue from time to time. For this patient, on arrival to the RHN, there was no issues with his bowel. However, he did require suppositories when on from when prescribed analgesic medication for 1 week. He had a urethral catheter in situ on admission and was previously having 2 bladder washouts per day. His mother was under the impression that these washouts would stop him from getting a catheter-associated urinary tract infection. However, it was recommended that the bladder washouts were decreased, as this regime would not prevent a catheter-associated infection, also known as a CORTI, which is a catheter-associated urinary tract infection. However, there was no clinical indication for the catheter to remain in situ, so the plan was to trial the patient without a catheter. We call this a TWOC. This recommendation was also handed over to the ward doctors, and they were informed and they were happy with the plan. Mum was informed and she was also happy, well, relieved that the catheter was going to be removed, because she actually thought that this catheter was going to stay in for a very long time. This information had never been told to her before or given over to her before. So the catheter was removed. Following the removal of the catheter for 1 week, the gentleman passed urine without any problems. However, towards the end of the first week, he began to retain residuals of urine in his bladder. He was bladder scanned. The bladder scan revealed 510 mils in his bladder. Therefore, the decision was made to use an intermittent catheter to relieve the blockage of urine and drain the bladder. Following the next few days, the patient was successfully voiding again. However, due to his dysfunctional bladder, he started to retain urine again, and then an intermittent catheterization management plan was put in place. His mum was informed, and we made this clinical decision as we didn't want to introduce an indwelling catheter which would remain in each day, as the gentleman did have some bladder function and he was able to urinate without a catheter. It was therefore decided that a regime would be put in place to introduce an intermittent catheter should he maintain high residuals of urine. His mother was given all the information of her son's care, and obviously the episodes of urinary retention, the management that we put in place regarding intermittent catheterization, and all the relevant details were given over to her. And prior to discharge, Mum had asked if she could come in and learn how to catheterize her son intermittently should this happen at home. And to be honest, the percentage was quite high that this will happen and would happen again. And we also informed Mum of this information, that on discharge, the likelihood is that he will void for several days, maybe a week, maybe 2 days, 3 days, nobody knows. But at least by having an intermittent catheterization regime in place, this would then relieve the blockage. And Mum was then, it was arranged for Mum to come into the hospital to be taught intermittent self-catheterization. She was given a lot of information regarding the management of intermittent catheterization. She was also taught the urinary system. The demonstration was performed on a model. Various catheters were shown to her. The technique of catheterization was demonstrated, and Mum, to be quite honest, Mum had quite a lot of knowledge about intermittent catheterization and bladder dysfunction, because she had done a lot of research leading up to this appointment with the Continence Nurse Specialist. Following discharge, a home delivery company the patient was registered with the home delivery company so that his products could then be delivered to his home address. And the relevant details of our email address and telephone, and any contact that she needs to have with the Continence team was also handed over to Mum prior to discharge. Since discharge, Mum has contacted us, I think, on one occasion, and it was regarding catheter equipment. And I believe she has taken over his urinary management care at home. So, and that was the education that was involved in with this patient's mother. Oh, if anyone would like to ask any questions to any of the team, please feel free to do so.
Thank you. So we have got a few questions. The first one is from Helen. What plans do you put in place with professionals in the community when discharging an enterally fed patient, e.g. involvement of HENS teams?
Was that enterally fed? Yeah.
Yes.
So that's a really good question. It's a little bit more complicated here because our patients generally come from all over the country and indeed all over the world. So we have to then look to find what is the provider for that patient. So just looking at the UK, different areas of the UK come under different contracts and therefore different home enteral feeding companies. So the first thing we need to do is establish who the provider is going to be. We need to then, my dietitian team contacts the community dietitians, and then we register the patient with the home enteral feeding company prior to discharge, so that once they go home, we put in place contact with the community dietitians and the first delivery of equipment for that patient. Now, we have a particular contract here with a certain company, but there are 3 other companies out there. So it may well be that when he gets home, he's going to need training, or the care team and the family team are going to need training on that particular equipment, which is different to what we've got here. So one of the things we also need to arrange is for the home enteral feeding company concerned to get their education team in to teach them about the pump, the equipment, etc. So yeah, it's a bit complicated, but that's generally how we go about it. Does that answer the question?
I hope so. Helen, if you want more expansion on that, do just drop us another note. We've then got another question. Is it typical to have patients with PEGs to arrive with overgranulated stoma sites?
Yeah, it is. I think for me, it's one of those things. I think you have to understand the journey that the patient's already been on. So they've had a very severe injury. They've been in intensive care. Very often a feeding tube is put in pretty quickly. It's pretty, at the beginning of the journey, it's pretty obvious that someone's going to have long-term feeding put in place. And I think with everything else that's going on, tracheostomy, etc., I think once that feeding tube's in, shall we say, I don't think the care of the stoma is high up the priority list. If someone's got a brain injury, perhaps they're unstable clinically. So I think actual stoma care isn't great in an acute setting. And I think that's partly because there are other more important things going on. So when they come to us, generally speaking, we have a high incidence of overgranulation in our patients that are coming for assessment and rehabilitation. So they tend to come in here, the nurses do a quick body assessment, as Christine was saying, they're looking at all the skin, including the stoma sites, and that's when I'll get a referral. But the good thing about it is generally these patients are really quite easy to treat. So I tend to see them for the first sort of 3-4 weeks. And then I don't see them again. That's kind of it. Once we've treated it, that tends to be it. Generally speaking, it tends not to recur.
All right, thank you. If anyone else has got any other questions, do just pop them in the Q&A tab. We've got one more at the moment. The question is, what would you suggest for a patient whose catheter blocks frequently, despite daily bladder washouts? They're on TPN.
Okay, I'll pass you over to Marie.
For a patient, I mean, it depends on the material of the catheter. All silicone catheters are much better than hydrogel catheters. I don't know if this question is related to hydrogel or all silicone or just catheters in general. Also, position, you'll find as well that a lot of patients, because someone is a female, that someone will insert a female catheter when actually, in fact, the male catheters are actually better for drainage. So within the RHN, we do not have female catheters. Every patient has a male catheter because it's better drainage. We've also got a guideline in place where all our patients' catheters, although they can remain in for 12 weeks, they are all changed at 10 weeks. Because, that also stops a lot of blockages as well, because we found that a lot of blockages were happening at around 11, 12 weeks. Also, our patients are not mobile, so that's another reason. It could be positional. Also, each patient will have their own individual management. As I said, 12 weeks, the catheter can remain in for 12 weeks. We have a guideline here where we change them at 10 weeks. However, it just depends on each individual. We also have patients here that catheters have to be changed at 6 weeks because they actually get corties, which are catheter associated urinary tract infections. Bladder washouts, obviously there's not an actual, for bladder washouts, there's nothing set in stone. You just have to keep reassessing. Fluid intake is also another aspect which can also help reduce catheter blockages. That can also have a big impact on catheter blockages. So you're looking at fluid intake, also position of the catheter, the material of the catheter, because hydrogel catheters do not have a better drainage. They don't drain as well as the all silicone, if that makes sense. I hope that answers your question.
Thank you. I think it does. I hope it does.
Yeah, so there's various things that can cause catheter blockages. Yeah, constipation as well. If your patient hasn't opened their bowels for a couple of days, that could also be another thing that you would have to assess and look into. Yeah. Okay, I hope that helps. Anyway.
Thank you very much. Well, that looks like that's the end of our questions. So I'd just like to thank the whole team. Thank you so much for your presentations. Thank you for taking time out of your day to chat to us. This is recorded, so we'll pop it on the website afterwards for anyone who missed it. And we run them monthly, so do log in and join us next month for our next open lecture. But anyway, thank you, everybody. Thank you so much.